Right. What Dr. Beth Hunter and I are going to talk about might seem a little out, but this whole conference was really off the wall anyways. We're going to talk about communication, we're going to talk about advocacy, we're going to talk about patient-centeredness wrapped up in the area of research. And why are you learning research? I know the PT students go, we have to do our one project. Yes, you do have your one project. But it was actually the project that Dr. Hunter and I got funded for about a year and a half ago that actually led to this conference today. So we're going to give you a little bit of the science behind it, but it also ties into exactly what we have been talking about. Okay, learning objectives. So what we're going to be talking about is patient-centered outcomes research. The first part, does that not sound fairly familiar to you? Clinicians to be, patient-centeredness, outcomes. That's what you're supposed to be doing with every single person. We're doing it, the flip side is it's driving our research. Because depending on the particular article or the little blurb fact sheet you're getting from Washington, D.C., they like to point out that about 85% of NIH, National Institutes of Health funding, hasn't helped anybody. And part of the reason is they weren't asking the correct questions sometimes. And sometimes you only ask the correct questions when you actually work with the person that you are doing the study with to help you ask the relevant questions. So how do we engage clinicians? How do we engage individuals with a particular condition to be part of our team? How do we engage them to ask the right questions so that if you answer it, you should be able to put it into practice because they've already bought into it. So how do we engage? And that's a lot of what our overall KARRN group has been doing for the last 12 years. How do we engage individuals so that we can work with them? Because as a clinician, there's only so much therapy I can do to somebody, and then it doesn't work anymore. If they're not engaged, I mean, I can do work with somebody for an hour, but there's 23 more hours in the day that they had better be doing some sort of therapy at home, right? If not, you get to yell at them the next time. Okay, so we received an engagement award, and the sole purpose from Washington, D.C. when they funded us is how do you engage folks? How do you actually get them to buy into being part of your team? Well, we've been doing it for 12 years. I mean, the KARRN group we don't have an external advisory group at all. The people we work with are us. We meet the first Tuesday of every month. We use technology in that. Dr. Rebchevsky is a founding member. Jason Jones, Carolyn Wallace. The Kincaids, they're all part of our team, as well as Dr. Salas, ARH, Brain Injury Alliance of Kentucky. All of these organizations we have been working together with for quite some time as a team. How do we bring them together so that we can ask appropriate questions? So that when we answer them, we can do something. Because everyone thinks that you need to wear a white coat to do research. PT students, what is research? It's asking a question. That's all it is. As a clinician, you are asking questions every single time you assess somebody. My 5-year-old asks more questions from the time I get into my house to the time I get to the kitchen. He should have 4 or 5 PhDs every single day. That's all it is asking a question, but the hardest part of research is asking the correct question, and a question that actually is relevant to somebody. So this was part of what Beth and I have been working on. And I will, before I forget, acknowledge that the cool thing about our engagement award is that it's not just researchers. We have multiple partners on it. You met Carolyn, is actually one of the research members. Keisha Hudson, who you had referenced, is our stroke navigator out in Eastern Kentucky. Violet Sylvia, who is the systems director for rehabilitation services for the entire ARH system. And she's also one of our founding members. So we have multiple perspectives, multiple people working together on this particular project here. So the goal for this one, because we know communication is important, but we also know information is important. So what is the information that is actually important to someone with a spinal cord injury, stroke, brain injury? What is important to them was the first question. But more importantly, where are they finding this information? Are they learning from their community? Are they getting it from their healthcare providers? Or heaven help us, are they getting it off the net? Guess what? There's a lot of terrifying disinformation out there. So where are they getting their information? And then can we take them and turn them into a research team? And these are just common folk. Can we turn them into this awesome force for good? Okay. So the objectives for this grant is A, what are their information needs? And this is something we have been looking at for 12 years now. We have done multiple studies. We have looked at people once they go back home. What do you need when you go back home? Therapists. Your folks out of inpatient acute will remember almost nothing that you teach them. It's your reality. We've had lots of people telling us over and over again, every single study, they don't remember a lot of what you taught them when you send them home. So that's why we need to come in on the backside and reinforce what we are teaching them so they better understand. Okay, what is their perceived value of patient-centered outcomes research? It's like, no one knows what the term is, but the reality is we all use research. You look on the news and they give you the statistics, or you're looking to buy a new car and you're looking at all the numbers from Consumer Guide. You're doing research. It's like, do I take this medication versus this medication? Well, this one the doctors say is better for you. You just did research. You've asking questions. So what is the perceived value of research? What is the comfort that people have with being part of a research team? This is where most people go, oh, you need to have the professionals do this. And what we have been doing for multiple years now is trying to break down that concept and saying every single person has the capacity to ask a question, which means every single person has the capacity to do research that is relevant. It really isn't that hard. I've been doing it a long time, almost as long as Dr. Ebchevsky. So, and the other big challenge, since we work so much in the rural community, is how do we actually engage people? How do we actually physically go meet people who are now dispersed? We work with a lot of people out in the various counties around Perry County, and unfortunately when we go out to Knott County and we're working with some of the people in the hollers, it could be about a 25-minute as the plane flies. It's about an hour and a half as the car drives. And it's also places that my GPS doesn't work at all. But I meet with some really, really phenomenally amazing people. So how do we actually engage people? What is the best way? Everyone says, oh, you put flyers up, or you do an ad on the TV, or you do the ad here. What is the most effective way to want to get people to be part of your team? So we have been building a lot of our methodology around that question. Why is this important? It's important for people who are in urban areas, but it's also very important for people in the rural areas that have a much decreased access to various resources. They don't have the healthcare providers. Dr. Salas just said it. There are 5 people that are spinal cord injury specialists. Most of them are in Louisville or they're in Lexington. They're not east of here, really. It's like, how do we get that kind of knowledge out to where we need to get that knowledge? Okay. And how we access the system is going to be very, very dependent on many, many other characteristics. So how do we work within the rural community? I mean, I am not from Kentucky, but I am from northern Wisconsin. I'm from a really small town up there too. Trust me, I know what it's like to be very dispersed and away from the different systems. But how do you also work with what they have? Because the resources in a community also, there's a lot more than we think about. And why is it also important that we keep talking about disability here is, unfortunately, 2015, our disability rate here in Kentucky was 17%. It jumps substantially when we're talking about our rural communities. We have significantly higher levels of disability in this area. Okay. And when you add upon that the fact that we also have some of the highest rates of diabetes, obesity, hypertension, cancer in the United States, you pull up any map from the Centers for Disease Control, we glow red for everything you do not want to glow red for. Most of the time we go, thank goodness there's West Virginia. But we now have superseded them and they go, thank goodness for Kentucky. And then we all say, thank goodness for Mississippi on 2 of them. But that's our reality when we have our individuals that we work in our care transitions program that are post-stroke. I would love someone who's had a stroke and is only diabetic. We don't have that person. They're diabetic, hypertensive, they smoke, they're overweight. That's a fun person to work with, and that's most of our caseload out there. How do we work within those parameters? Here's the one that's really, really challenging for us. On average, we have 30,000 cases of TBI in Kentucky. Start doing the math. How many beds do we have in acute rehab in this Commonwealth? We do not have enough to handle 30,000. Okay. We have on average 24,000 cases of stroke in Kentucky every single year. Once again, do the math. Do we have the facilities and capability to handle them to the level we want? Okay. It's a challenge here. So how do we really work within this environment? The only way we can work in this environment is we must be completely working with the people and the environment to have some sort of impact. Okay. Okay, we've already gone over that a little bit. So we'll talk a little bit about the methodology of our study.
All right, so we actually can't call it research. Corey will slap our hands. This is not research, but it's a project. But that's something to keep in mind when you're thinking about requirements for doing a project or a research-based something. It can look so many different ways. You know, Pat said, you don't need a white coat, and that is absolutely true. What we've found, and we believe in strongly, is it's got to be grassroots, ground up, learning from the people living with whatever we're talking about, wherever we're talking about it. And so the research, or this project, had to go in this way too. One of the reasons we got the funding was because we've already been successful with KARRN and developing that. That started from a very small qualitative spinal cord injury study. Let's talk to people in Eastern Kentucky with spinal cord injury and see what are they up against. And it just snowballed and snowballed. And funding came because we were hitting a spot where people saw the value. We had great buy-in. We added stroke and TBI. So when this opportunity came in, so we had a process that we followed to do that. When this funding showed up, it's like, well, look, let's just take that process that we've already used and been successful with, and now focus it on this idea of let's learn about how to involve people in research and developing questions and being sure we're on target. But we could also expand our base. And one of the things that happen, and this is what happens in every project, things you do not expect occur. And we just have been overwhelmed with need from the traumatic brain injury group. So that was great for us to get more partners and more people to extend our reach. But so when we took this project on, we used the process that we used with KARRN, and that is, let's go talk to people. We can't, the whole key to community-based research, community-based development is the last thing in the world anyone wants, is for me to come tell you what you're supposed to do. Because I know, because I learned it in a book, or I read a research paper, and I know this is what's going to help you. Well, I don't know, and it came up in other people's presentations. The life world idea. We can tell you, I mean, there's a lot of research. We know what helps people, but it doesn't help everybody because maybe it doesn't fit into their lifestyle, or it's not their priority, or they've got so many things above it because they live in a really rural or remote area. So you got to go talk to the people. So the first step of the project was we wanted to come up with an assessment and needed to come up with assessment, but Corey wanted us to. Something that could be used by others that we could use in the community to predominantly find out how much do you know about research, how afraid of it are you, and where would you fall in the spectrum? Because there's a wide spectrum of participating in research. So the first group we did in-depth interviews, sort of key informant. So in a way, you're cherry picking, but you're really going to people that you know are going to give you good information. So we talked to people with TBI, stroke, spinal cord injury, providers. Let's think about what we need to do to develop this outcome or this assessment, but let's figure out what topics are important too, because the whole goal of this whole thing is that down the road, we have a nice network of people that feel empowered and that will share with us and help us prioritize what the research questions will be. So the key informants or in-depth interviews helped set that foundation. We took that information, thought about it, pondered it. We have our core group that Pat mentioned. We're meeting regularly. We're talking about, like in qualitative research, although we're not calling it that, but it's using qualitative methods, taking their information and analyzing it, coming up with themes, coming up with what rose to the top, what were they not interested in. I think one of our first things was chronic condition management. Oh, of course. Everyone needs to worry about. No, that didn't come to the top. And that would have been something I think we probably would have moved forward with. But when you're dealing with spinal cord injury, stroke, TBI, you may be thinking about something else entirely. Like, I just want my brain injury to start getting better. I'm not worrying about chronic health right now and exercise and wellness. So that was our first learning experience. Let's back off. See, we were coming at it from an academic point of view and not the lived experience. So once we got that information, compiled it, revised this assessment tool, then it was a matter of developing kind of small group meetings, working groups. We wanted a variety of people again. We wanted as much breadth as we could location-wise. We were meeting in Eastern Kentucky. We were meeting in Lexington. We were in a variety of places. And we took the information from the in-depth interviews and said, well, this is what we've heard. What do you think? So the next level of development now. We're focused in on what we've heard from the key informants, that these are topics that need to be brought up. Now we want to hear from a bigger group and a variety of people. So those were great meetings. We took that information, compiled it, tried to figure out what's important, what's not. We're just sort of getting to the end of that part. The last step, and this is exactly how we did the KARRN development too. We're very close. The last step will be coming up in September. We're going to have 2 half-day meetings. That's new. We were going to have one. When you start learning, geographic distance is a huge issue. So if you're working in rural communities, people that are living in Hazard, I mean, we knew we were going to have a meeting in Hazard, but people that are now living in north of Lexington or western Kentucky, they're not going to get to Hazard for that. So we quickly realized we have to do 2 half-day meetings and, again, try and get as many people as we can to attend them that have been part of this project with us. And now it's kind of where the rubber hits the road. Let's see, who's really interested? Who wants to stick with us in some capacity? We're not asking people to sign their lives away. We're not asking for them to be writing grants or editing papers. It could be that they are just going to be the ones that share our results in their church group. I don't know. It could be anything. There's so many levels of participation they could do. So at these meetings, we have now generated a list of the topics that have been coming up through this process, and we're going to present those and be open to new ideas to these groups with the hope that we come out of these half-day meetings with, say, 2 low-hanging fruit, maybe 3 inexpensive projects, things that we could hit the ground running with. We can show progress. We can actually provide something back to the community, big part of being community-based. And then we also want to generate plans for bigger projects, longer-term projects, things that we're going to have to get grant money for, which is always a precarious position to be in. And for people that are new to being in the research process, it can be a little depressing if you're thinking, okay, let's get all excited and maybe in a couple years we can do a project. So that's why we've learned, again with KARRN, the importance of these smaller projects that may not seem earth-shattering, but really can be very helpful to people immediately. So the plan is to come up with some of that. Quickly, we ended up talking to 17 people in the in-depth interviews. As I said, it was a variety of the providers, SEI, stroke, and TBI. Caregivers were invited as well. The work groups, we ended up doing 7 of them, and total 33 people took part in that. And then we have half-day meetings coming up, and I think at this point we're going to have maybe 12-ish in each group.
12 in each group. Yeah.
In each group, probably. But we'll see how that all goes. Some things, there was a questionnaire we did right off the bat. So what are the priorities? What are the things that you're interested in? Caregivers, for example, said accessing the proper providers and doctors. We've heard that a million times today. That was the number one. Caregivers are interested in prevention and wellness. That's both for themselves and for their loved one. Caregivers are under a lot of stress. They've got their own health issues. Paying for health care, this insurance issue, that's a big deal. For the patients, chronic disease management showed up for some. Usually with someone who's been living independently and for a longer period of time with whatever diagnosis. They also need to help with accessing doctors and providers, but then they also want this specific information about their diagnosis, which makes sense. Where are they getting it? Doctors were the number one provider of information, which makes sense and holds true across the United States for most health information searching. But also remember how much time you get with your doctor. So it's an important moment. We're back to that communication factor. Other healthcare providers, the internet, support groups, peers, that came because we had a very strong stroke contingent in our project, and Pat and others have developed the stroke support group and Hazard, and that's just been the best. There were no support groups in that region for them. And so having developed this, it's just become an incredible project, and something that, I think we would propose would be beneficial to a lot of people in a lot of different communities. So why are people not looking at health research? I'm sure you all have your own reasons of why you might not want to look at health research. It can be a little boring, maybe. Too much information. How do you weed through what's important to you? Hard to find. If you're not in an academic setting, you don't have access to all these articles, or do you know what's, as Pat was referring to, what the best or the most reliable websites are, or can't understand the information. Health literacy is a big thing. We all have health literacy issues to one degree or another, more so if you're in a stressful moment or your life is in a big flux from a major change. But reading academic articles is going to be hard for anybody. So the findings that I'm going to share with you will be very repetitive at this point. When we got this information, it's what helped us decide who did we want to speak here today, because these were the things that rose to the top. And so number one, this idea that there's no individual. You are not an island. You are part of a system, of context, whether it's just family, but we've got neighborhood, we've got communities, we've got the healthcare system, we've got policy and laws. You can't just look at an individual in isolation. Things that are needed, people have to be very proactive. To be proactive, you have to have a certain amount of belief in yourself or self-efficacy, believing that you have a right to stand up to, the doctor or the this, that, or the other. You have to have some degree of health literacy or understand what your limitations are so that you can ask for help. Communication skills, this is on the family patient side as well. Shared decision making, being ready to step up. The people we're hearing talking today are advocates. They are out there. They are motivated. They're activated. Not everyone is, but it's important to help your patients, your clients, your the family members surrounding them, to help them realize how important it is for them to take control and to try to be part of a team with their healthcare providers, not to be passive. And leading to this being an advocate in education. The healthcare systems, we've learned some things about that. Now, this is going to be much more of a long-term process. It's much harder to change a system. But offering the appropriate services. Rural, this is nothing new. We knew we would find that. We find that with every group. You're going to have limited access to experts. Some people don't want to go in a small town and have everyone know their business by going to the doctor that's their neighbor. You know, some people want to go away from their little small town anyway, but it's having access to what you need. Flexibility. These cutoff things, and I know, I mean, you know, you have to be realistic. There's money involved here. But being flexible, we heard people that were talking about having great experiences with their primary care doctors and some that didn't. Things like, oh, I can just call. They don't make me load up everybody, get over there, sit and wait, you know, because they need kind of quick answers. And the doctors were open to that. It's like, okay, call me before you make an appointment. Let's see if you really need to come in and talk it through, or do I just need to send in a prescription for you? Being accessible, having physically accessible medical care. Unbelievably, that is not a guarantee. All right, so here are my little visuals. You all can just enjoy or not. Some of us are visual, like a nice little picture, put it in a diagram. But so everything I've just said is here, looking at the person within the context of these other systems, the community or their healthcare systems, being activated, understanding that it needs to be a team approach. Very few of the people that we're talking today have one doctor. They have multiple doctors, multiple therapists. So the communication and the team and trying to keep everyone organized is a big task. So once we took this to the work groups, they just kind of consolidated it. And just, you know, rising to the top is this communication idea. And it has to be between all levels. You want the individual, the family members to communicate well with each other, to be on the same page, hopefully. You want your providers to communicate with each other, and you want the provider, patient, family communication. You need partnerships and collaboration. We talked about the family or person-centered care, continuity of care, transitions of care are where problems occur. And we've done studies with stroke and TBI and spinal cord injury, but the transition from, say, Cardinal Hill or an inpatient rehab facility to home is a big transition. And no one's prepared for it. You can't be. You don't know what to expect till you get home. And all of a sudden you're in your real environment. None of your habits and routines are the same. You're going to have to change everything. Might not be accessible. I believe you start feeling a little isolated. You're not right there with the doctor. You're not seeing a nurse. You're not seeing a therapist every day. Or it's, you know, you have to work a lot harder now to get back connected into the system and be sure that you're not just falling off the face of the earth. So, I mean, two areas, and again, nothing new here, but two big areas that we would be looking at now, research-wise, at least starting to hone in. There's a big education component. We could be doing something about educating health teams on how important it is to have a team mentality and to have the family and the person involved in it. We could be doing education with families on how to be a self-advocate and how to feel confident in shared decision-making and to expect some things that maybe they don't. The advocacy, help people understand what it is to be an advocate, or you know, what skills are needed, what are the tricks of the trade. There's certain things like trying to finagle through the TBI waiver system that you can learn from experience. Talk to people who have done it. Help advocate for those who have had more newly injured. So my drawing got more complicated after we got the last bits, but it's all still the same thing. It's just looking at trying to figure out what you can do with something like that is you can point a finger at one arrow or one box and say, that's where we're going to start with our research. It helps you break it down in your mind so you're not overwhelmed, but you can also see where things interact and what you might think of for outcomes or different types of interventions. So I think you all know at this point, we will take home the message. I think we've communicated this to you. Communication, it's the root of everything, and it's not just in healthcare. I mean, any bureaucracy or system or complex environment, communication is hard. It's often got glitches, but it's really important to at least start with a good basic skill set and expectations. Partnership and collaboration, no one's by themselves, and having access to care. So for rehab professionals, I hope this helps you think about some obstacles and realities. You've heard from people, the clients that you're going to be working with as a whole, but then maybe in particular those that are going back to rural communities or are in your rural community, that they may need more support. And you may need more sensitivity to be thinking about all these things like, oh, wow, you know, what do we do to help with this situation? But you're also the group that's really well suited to being a conduit of information and being advocates. In a way, you have to. It's part of your job description. But you get to spend more time with people than, say, the physician. You get to develop these relationships, hopefully, and see them over time. So don't only think in the nuts and bolts of this one issue or what. Think of them in context of their lives. And we've heard that from the other speakers today as well. But that transition home, and maybe you're going to be the person in the community they're transitioning to, and that would be great, because they really need a good cushion to hit when they get home in reality. And it may be important for you then to be strong advocates for your profession in terms of making sure you get the information from the other hospitals. You understand the whole picture and who all's on the team. I mentioned, you know, big take-home point, they're the people with TBI. There are a lot of people with TBI in the state that feel they have been abandoned. They get so far in therapy, insurance stops, it becomes very expensive. There's often transportation problems. They may not drive at all. You know, there were a lot of issues that came up. And the caregivers for people with TBI are working hard. And in some cases, we're talking just about 24 hours a day. There were differences, and we knew there would be with these groups. You know, we kind of lumped together TBI, spinal cord injury, and stroke, and there were definitely differences. Each diagnosis has its own thing, but some of these were just global. The access, the rural, the communication, the feeling abandoned. So this communication collaboration would hopefully, we believe, help all of these. And this continuum of care issue, again, a communication thing, in a perfect world, each provider would know what had been said and done, and it goes right through the continuum instead of kind of starting over or backtracking or taking a step ahead and they've missed something in the interim. I think I'll let Pat talk about next steps, of which there could be many, infinite really.
Yeah. Right. So you're seeing how all of what we've been talking about today interweaves into what we do. It's all the services that we have developed over the years, the projects we have developed over the years. So what we need to do is continue to engage, to work with the individuals. Hopefully by the end of September, we will actually have the projects. And it's not research projects. These are projects that are going to have an implication on people's lives.
Which can be researched too.
Which can be researched too, but it's engaging them. No different than you as a clinician need to engage your folks. Once again, they're not a tick mark. It's not a 15-minute slot that you get payable. They're individuals that are going to go way beyond your 15-minute mark or 30-minute mark on the rehab floor. We need to work in partnership because there's certain things we can't get our hands on. There's things you won't as a clinician get your hands on, but you need to know who you can go to. And many times it isn't the healthcare system. They aren't the ones that actually do something. There are all these little pockets of groups that you can go to. And that's what we do is we work a lot of partnership. And when you figure something out, it's really good if you figured something out at Cardinal Hill and it works great, or if it works at ARH Hazard and it works great. But you need to get that information out to everybody else, so places aren't reinventing the wheels all the time. Best practices. We're supposed to be doing that, but we can only do best practices if clinicians are actually talking to each other and find out, I was like, oh man, this does not work at all in our clinic. What works for you? You need to be sharing knowledge amongst yourself so that we can share with our patients. And then you need to be listening to them. Because we've had several projects that we got rocking and rolling, and about a year into it, they're going, oh, that was never going to work. And we're going, well, that would have been really cool if you would have told us about a year ago. And it's, why not? Because of X, Y, and Z. It's what Dr. Hastings was talking about. It's what Dr. Helm was talking about, is like, we need to know the context of why things are going to work or not work for each individual person. Okay, so any questions? Reason why we threw it out is hopefully as you graduate and you get going, you will be able to be working with us. We will be able to tap into your collective knowledge as we go on so that we can impact the people that we have kind of taken an oath to be protecting and working with.